Next up, I want to have Louise McCarthy from the Community Clinic Association of Los Angeles County. Let's give her a round of applause. Let me start with the same kind of question. We'll get into big stuff and 100,000 foot and the 30,000 foot, but when you go back to your office, what's in your inbox, the stuff that you are focused on right today, this week, this month, in terms of delivering value for your members?
What's in my inbox? What's on fire in my inbox? I don't know how many thousand unread emails. That's one of the things that certainly keeps me up at night. The things that are most pressing for us right now, I think, for us, for LA County, just a quick, the Clinic Association represents 65 community clinics and community health centers, including Planned Parenthoods in Los Angeles. That's 350 full-time sites, 1.7 million patients seen each year, and the majority of those patients now, thanks to the ACA, are on Medi-Cal. So we work at the county level, at the state level, and the federal level, wash, rinse, repeat. So what we end up seeing often is that we just take turns in our advocacy, in our issues, in looking at, the county. We're working on our county indigent care program, then we shift to the state. One of the most pressing things for us right now is an unfortunate executive order that came out in January where the governor, very well-intentioned, proposed to carve pharmacy out of the managed care program for Medi-Cal. So for community health centers and community clinics statewide, that's over $150 million in revenues that come to them through the 340B program at the federal level. So challenging is to say, now how are we going to manage our budgets once you've taken this revenue stream away from us and brought it up to the state level? So this is mildly or extremely terrifying day to day, looking at how we're thinking about that. The proposal has three components to it. That 340B piece is just one of the three. There are good things in other pieces of the proposal, so it's just an unfortunate thing that's keeping us awake at night. Yeah. Similarly, looking at how do we get our bills that we've been pushing at the state legislature past the finish line, get them signed. We have a bill that would allow health centers to get paid for providing mental health and primary care services on the same day. This is our fifth or sixth time. Yep, I heard a couple claps back there. We've been trying. The Department of Finance loves the current situation because they can get 2 for 1, because our members are actually providing those services. So that's another one that we're looking at really closely, and hoping that finance won't rule, that actually care will rule. And we think about the zeitgeist of our administrations, whether that's at the federal, state, or local levels, making sure that it's not about an audit or the finances, it's actually about the patient. Yeah. So those are big things. And I won't, I cannot skip over the federal administration and the nightmares that are in my inbox every day with every new published rulemaking, whether it's public charge and the assaults on the immigrant population, the folks that our members serve who are afraid to enroll in healthcare programs because they think that'll eliminate their ability to become documented citizens later, from Title X and family planning and the gag rule that will prevent providers from offering clinically sound guidance to their patients. And then additionally, other things as we continue to see come out, even chain CPI. I never thought I'd be thinking about chain CPI, but if this goes through, the way in which we calculate our federal poverty level will be adjusted, and it would be to a blue state detriment. So those are the types of things. It's not one thing that's keeping me up at night. The bags under my eyes, I'm not sleeping, thanks to the current environment. But we're passionate, we've got passionate advocates, and a lot of strong supporters, even supporters that unwittingly do things that could harm us in the end.
So we talked about this a little bit last evening, so let me step back. That's sort of the list of things that you have in your inbox you've got to kind of respond to. Then there's this list of other things that are kind of big and amorphous and don't show up in your inbox directly, but which are going to have direct impacts, and that is, in this case, a potential recession. It'll happen at some point. Mm-hmm. Feels like it's getting closer every day. Probably is. I think that's just how time works. what are you and your members doing? What are you thinking about? What kind of conversations are you having within the sort of tyranny of the right now to plan for that?
So we're actually working on this right now, trying to pull together a program that would be in partnership with the Association of Public Hospitals and the California State Primary Care Association, looking at the public and private safety nets and saying, let's look back to 2007, 2008, 2009, the previous recession. What was it that hurt us? What was it that helped us? How did some organizations survive and some didn't? I actually lost 3 members in 2010 as a result of the recession.
Meaning organizations?
As organizations,
Yeah.
they closed. 2 of them closed outright, and one was acquired by another health center that took them over to help them. I'm already seeing this year, one merger has already taken place between our members, 2 of our members, and there are 2 other merger conversations with other entities happening right now as well. So folks are looking at the tea leaves and saying, can I survive? Does it make sense for me to continue to operate as a single site, standalone organization, or do I really need to think about merging with someone larger who can help me survive and continue to care for my patient population? So really getting into the finances of this, looking at how do you clean up your internal books, your finances, your productivity, maximize everything you're doing, so when the recession hits, you're well poised. I want to be really clear, when we talk about the recession hitting and impacting the health centers, it impacts the communities that they serve. Mm-hmm. These communities don't only get care from the health centers, they also get jobs from the health centers. Healthcare is one of the largest growth sectors for middle skill jobs in Los Angeles County, and this is jobs for people who have a high school equivalency or up. So if we're thinking about where opportunity comes from, it comes from healthcare. If we're trying to stave off crises, these would be crises impacting not just the healthcare services, but the healthcare jobs. I do want to say one other thing that needs to be front of mind as we look at this is Medicare and the aging of the baby boomer population. We had this massive expansion of Medi-Cal in 2014, put all these people on the rolls, and all of our health systems expanded and grew to serve them. Did they expand and grow to serve them when they become seniors and when they are in Medicare as well? Yeah. Because if they created this capacity and those folks go thrive elsewhere, pun intended, they would, what are we going to do with that excess capacity? What are we going to do with that? So I think it's just really critical, and that also can be a planning tool as we think about the recession, is how do you manage this patient population as they age into other payer sources and make sure that you're able to serve them?
So what does that payer conversation look like? I asked Don the same kind of thing. I'll ask John the same sort of question. It feels like the provider-payer relationship is rapidly evolving across all categories of the provider space. What are those conversations like at the FQHC or community health clinic level vis-a-vis value, vis-a-vis mission alignment, planning for the next recession, some sort of integrated contracted model?
Something you mentioned in talking to Don was this concept of associations is digging in their heels and not wanting change. And what I love about serving the health centers and being in this type of association is we are a push the envelope association. We actually, a couple years back, ran a bill authored by then Senator Ed Hernandez looking at payment reform, at changing the way that community health centers get paid, their prospective payment system rate, our sacred cow, okay? We brought our sacred cow out and said, let's talk about this. In the end, it ended up dying at the feet of CMS, who wanted to put our payment system into a waiver. We're willing to transform, but once you start waiving things, we get a little bit nervous, especially with this administration, to be sure. And we're willing to have those conversations again. Let's get paid differently. Let's think about not just the face-to-face visit. That shouldn't be our priority. Yeah. It should be about making people well and making sure that, especially for a low-income person in Los Angeles, you should not have to take multiple buses to come in to see a physician when it can be handled over the phone or by email. I benefit from that in Kaiser, who I love, and I'm able to not have to take time off work. So if you're thinking about the burden that puts on a low-income person, that's huge. Additionally, when you're thinking about payments, sadly, because of the system that we're in and that we're working within with PPS, there's this assumption that we can't operate in other programs, like, for example, the value-based payment program that the governor put out in the January budget. Did not include community health centers. No VBP for us. Your PPS system pays for it. You're fine. That's good. And so we have to find a way to operate within the value discussion, within the alternative touch discussion, and really think about aligning all of these different systems. It is challenging. One of my favorite charts that I got was made by a colleague at LA Care, which shows how payments flow from community health centers through IPAs, through health plans, and the state. But it is a nightmare type of chart because you've got mental health care, you've got substance use, you've got all of these different dotted lines moving around. And so you're thinking about how do we actually align our systems, start to work more globally on patient care as opposed to being what is the payer source that pays for this one condition right now? And how do we just leverage that? And then, oh, nope, now you're seriously mentally ill. We have to move over to the county DMH system and that payer source. And there's a lot of finger pointing as to where the client belongs to say, oh no, that's your problem, you pay for this. Oh no, that's your problem, you pay for this. So we have to figure that out.
Let me clarify on the PPS question.
Yeah.
Because the PPS payment methodology is essentially a cost-based methodology or ties back to a cost-based methodology. Is that floor, or the floor that exists in the PPS model, is that something that is on the table for your members? Because a value-based payment world has upside and downside, but to have the downside, you got to
We're already living in downside risk because the caps that get put into it is quasi-cost-based reimbursement. There actually used to be cost-based reimbursement before PPS, but now, for example, if you're in San Francisco and you're putting your costs in your public prospective payment system rate, and you show the state, here are the costs that account for our services. The state will say, you're paying a physician that much? There's a cap on how much of your physician's salary can go into your PPS rate. And that cap is $140,000 in San Francisco? No, thank you. Exactly. So we're already in the basement. We haven't hit the floor.
That's not really a real cost-based payment methodology, is it?
Exactly. It's all about exclusions. And I think that's the piece where we have to change the relationship with the Department of Healthcare Services. I think there's a great opportunity with Dr. Gali and looking at the ways in which we can have a less acrimonious conversation around payments and think about care and about the true cost of care and how to really maximize our systems, because this constant negating, this constant exclusion of cost, this constant, PPS covers that, PPS covers that. We need to get out of that and not be focused on the audits. Again, it's all about the auditors and it's not about the patient. So I'm looking for a reset on our relationship with the Department of Healthcare Services.
Awesome. Louise McCarthy, CEO of the Community Clinic Association of Los Angeles County. Thank you for being here.
Thank you.
Good stuff.
Yeah, thank you.